So good afternoon, all of us, and we are welcome to today's presentation on rheumatic heart disease. Dr. Ibrahim Mohammed Faisal will be leading us with this presentation. This is following our presentation on acute rheumatic fever. And of course, you would have heard during that presentation that one of the dreaded complications of which is rheumatic heart disease. So we're hoping that if you did learn a thing or two during the presentation on rheumatic heart disease, on rheumatic fever, we should not have so many cases of rheumatic heart disease coming up. Of course, these are diseases of poverty, diseases of third world country problems, like some of our colleagues who practice elsewhere would have joined us. It's rare to find these cases in the developed world. I'm sure at the end of it, we will learn a thing or two about rheumatic heart disease and be able to treat patients appropriately when we do come in touch with them. As we always say, throughout Dr. Faisal's presentation, kindly make use of the chat box if you have any questions or comments, so that at the end of his presentation, we would have a discussion around it so that all of us can learn a thing or two. Thank you once again for joining us, and join me in welcoming Dr. Mohammed Faisal Ibrahim. Dr. Faisal, over to you, sir.
Thank you, sir. Good afternoon. Please come tonight with joy if one can hear me. Good afternoon.
Good afternoon. We can hear you clear now. If you can go ahead with the presentation. Thank you.
Okay. All right. Yeah, so as Boss mentioned, today we are discussing rheumatic heart disease. The outline of the presentation is, first of all, we are going to talk about the introduction, definition, the epidemiology, and the risk factors that will really increase someone's or patient's chance of getting rheumatic heart disease. Then we go on to talk about the pathophysiology and how then will they present to you as a clinician. We proceed to talk about the diagnosis, investigations that are needed to be done to help you in the diagnosis. Then we proceed to the management. Yes, so we cannot talk about rheumatic heart disease without mentioning rheumatic fever. Rheumatic fever is a systemic disease which is characterized by a delayed response to an infection by the group A strep. These group of organisms are usually located at the tonsillopharyngeal area and affecting the heart, nervous system, the skin, and the subcutaneous tissue. It is believed to result from autoimmune response, even though the exact pathogenesis is not so clear. About 40 to 60% of patients with acute rheumatic fever will go to developing rheumatic heart disease. And I must state emphatically that the worst complication of rheumatic fever is rheumatic heart disease. Yes, so how then do we define rheumatic fever, rheumatic heart disease? It's a chronic condition resulting from rheumatic fever, which involves all layers of the heart, and it usually characterized by scarring and deforming heart valves. The commonest and the most severely valve affected is the mitral valve, followed by the aortic valve. The pulmonary valve is usually the least affected. Most patients with rheumatic fever will come with very subtle clinical presentation. So you need to really look for it before you can find it. So we say the disease is usually subclinical. About 53% of patients usually will come in this state. With the epidemiology, it is the most important form of acquired heart disease in children and young adults, especially in resource-limited countries, as Boss had mentioned. The median age affected is 10 years, even though some percentage can affect adults. Rheumatic heart disease accounts for about 15% of heart failure in endemic countries. It affects both males and females equally. The prevalence of rheumatic heart disease, in fact, this research was done in 2015 and published in 2017. It says that the rheumatic heart disease in 2015 was 444 per 100,000 endemic area and 3.4 per 100,000 in non-endemic areas. It is virtually disappearing in the mid-20th century in the industrialized countries. According to the WHO, in 2020, rheumatic heart disease accounted for about 256 mortalities in Ghana. It is the 48th leading cause of death. Ghana ranks 80th in the world. Every year, the disease claims 288,348 lives worldwide. It is about 2% of deaths. It accounts for about 2% of deaths from cardiovascular diseases. So as we mentioned earlier on, people who live in these areas or people who are exposed to this increases their risk of getting rheumatic heart disease. Number one is poor socioeconomic status, overcrowding, age. As I mentioned earlier on, it occurs in usually children and young adults. Climate and season. During the rainy season and cold weather, the incidence of rheumatic heart disease also increases. And the previous history of rheumatic fever can increase your risk of getting rheumatic heart disease. And there's also a genetic predisposition. So the MBL2 gene, so mannose binding lectin-2 gene patients or people who have this gene has an increased risk of developing rheumatic heart disease. So the organism implicated here with the, concerning the pathophysiology is the group A strep, the gram-positive cocci that usually located at on the skin and the oropharynx. So what happens is that for one to get this disease is just getting in contact with the organism. And once the organism gets in contact with a favorable surface like the pharynx, it attaches to the epithelial cells and produce some enzymes. These enzymes gives it the ability to damage and invade the human tissue. And I have to state clearly too that it's not all this group of organisms that are responsible for causing rheumatic heart disease. There are some notorious ones that are, implicated here. These ones are generally called the rheumatogenic strains of the group A strep. They are encapsulated. That makes it difficult for it to be resistant to phagocytosis. They also have a specialized cell wall that contains about 240 proteins. These proteins are called M proteins. And the M proteins, typically looks like parts of the heart. So when one is gets in contact with the organism, the body produces antibodies. And these antibodies are called the anti-M antibodies. And because the strep looks so similar genotypically to the heart tissue, the body mistakenly attacks the heart tissue, thinking it is the strep. So this causes a cross reaction with what the heart tissue. This is called antigenic similarity. And so this, because of this similarity between the heart tissue and the streptococcus, the effect, or let me put it this way, the reaction, the antibody that are being produced goes on to attack the host or the human tissue, which is what? The heart tissue. And it produces or releases some inflammatory markers like tumor necrosis factor alpha, interferon gamma. And this inflammation persists and cause lesion to the valves of the heart. So these pictures will help us to really appreciate more of what I'm talking about. So how then will they present? Usually they have a major, there are some presentations that we need to look out for. And those presentations are really considered to be very important in diagnosing rheumatic heart disease. So in this sense, it is categorized in what into two. That is what major and what minor presentations. So some of them generally they will come with carditis, polyarthritis, chorea, some rhythmic movement or involuntary movement of muscles, and erythema marginatum. These are skin lesions that are usually located at the limbs, the upper limbs and the torso, with a pink middle layer or middle area with raised edges. And some of them also come with subcutaneous nodules. So these pictures, this one is more of carditis. This is subcutaneous nodules. The next picture. The next one is the erythema marginatum I was just trying to describe. So this is chorea. This is arthritis. So with the minor presentation, some of them will come with fever, weakness, malaise, weight loss, and arthralgia. So when they come, we usually need to do, obviously, when the patient presents after taking the history, we need to do physical examination. In the physical examination, we need to pay keen interest in what listening to the heart sounds and possible murmurs. Typically, they present with apical pansystolic murmur, and these murmurs are of high-pitched, blowing quality murmur of the mitral. So this is usually found in mitral regurg that radiates to the axilla. Some of them also present with apical diastolic murmur that is heard in active carditis. Some patients will also present with basal diastolic murmur. It's an early diastolic murmur of aortic regurg. It's of high pitched and it's usually best heard at the right upper and mid left sternal border. And patients with rheumatic heart disease will also present with signs of congestive cardiac failure. So we need to look for exertional dyspnea, autopnea, PND, and the raspidal edema. Yes, so let's talk about rheumatic carditis. So rheumatic carditis is typically preceded with 2 to 3 week strep throat infection. In some cases, because there are some researches that also show that it's not always throat infection that could lead to rheumatic heart disease. Some recent research shows skin infections. People have antecedent skin infections that led to rheumatic heart disease. So this can result in pancarditis, but predominantly endocardial involvement, which usually involves the valves. About 53% of rheumatic heart disease, as I mentioned earlier on, is subclinical. Mitral regurg is the most common early valvular manifestation, maybe accompanied by aortic regurg. And let's note that isolated aortic regurg is uncommon. Rheumatic carditis can cause chorditis and chordal elongation, which consequently could lead to chordal rupture. Some will also present with pericarditis. In about 15% of acute rheumatic fever cases, they may present with precordial chest pain and pericardial friction rub. Some patients with mitral regurg may present with heart failure and left ventricular hypertrophy. And X-rays, because of the heart failure, could depict cardiomegaly. Yes, so with the disease course of, so we are now going to look at briefly the disease course of these valves. So let's talk about the mitral regurg or mitral valve. Usually they come with a mitral regurg, and this is leakage of blood backward each time the left ventricle contracts. This causes gradual dilation of the left atrium as pressure gradually increases as a result of chronic volume overload of the left ventricle. We also talk about the mitral stenosis. Mitral stenosis is almost always rheumatic in origin, although in older people, it can be caused by heavy calcification of the mitral valve apparatus. In rheumatic mitral stenosis, the mitral valve orifice is slowly diminished by progressive fibrosis, calcification in valve leaflets, and fusion of the cuffs and subvalvular apparatus. The flow of blood from left atrium to left ventricle is restricted, and left atrial apparatus rises, leading to pulmonary venous congestion and breathlessness. There's dilatation and hypertrophy of left atrium and left ventricular filling, because left ventricular filling becomes more dependent on the left atrial contraction. The mitral valve orifice. So we need to understand that the mitral valve orifice is normally about 5 centimeters square in diastole. It may be reduced to 1 centimeter square in severe mitral stenosis. Patients usually remain asymptomatic until the stenosis is less than 2 centimeters square. Some patients also will have the characteristic fish mouth deformity. This is used to describe a mixed mitral stenosis and mitral regurg. And in these ones, the deformity is more severe than an isolated form of mitral regurg or mitral stenosis. With aortic stenosis, isolated stenosis is very rare. It has a variable clinical course, but generally progresses gradually over years with a prolonged asymptomatic phase. Again, I want to stress that mortality dramatically increases after the development of symptoms. Aortic regurg, this condition is due to disease of the aortic valve calves and dilatation of the aortic root. The left ventricle dilates and hypertrophies to compensate for the regurgitation. The stroke volume of the left ventricle may eventually be doubled or tripled, and the major arteries are then conspicuously pulsatile. As the disease progresses, left ventricular diastolic pressure rises and breathlessness develops. Some also come with tricuspid valve disease. So these are pictures for us to really appreciate what I'm talking about. So this is what mitral stenosis. So you can see that there is what reduction in what the size of the valves. So the valve orifice. So these are other pictures. So there is what narrowing of. Okay, let's go. So this is a normal valve and there's a regurg. So when there's a contraction, there's a backflow of blood to the left atrium. Let's go. And then how then do we diagnose? Diagnosis of rheumatic heart disease is made after confirming antecedent rheumatic fever. And as usually, we diagnose it using a modified Jones criteria. So we consider two major or one major, minor. I think yes, so we use the modified Jones criteria. So we use two major or one major or two minor or please let me, I think there's, okay. So it's two major and one minor, or one with the major symptom as I mentioned earlier, erythema marginatum and subcutaneous nodules. Okay, let's go on. With the minor criteria, consider fever of greater than 38.5 degrees Celsius. But patients in high risk, we consider fever of greater than or equal to 38 degrees Celsius. Polyarthralgia, but we can also consider monoarthralgia a moderate to high risk population. We also consider PR interval for age on ESR greater than or equal to 60 millimeters per hour, or CRP greater than or equal to 3 milligrams per deciliter, leukocytosis, and positive truth culture for group A. With the investigations concerning the labs, I think it's very similar to what I just mentioned. So the ESR, as I mentioned, leukocytosis, positive truth culture, elevated anti-strep antibody titer, and the rapid antigen detection test. So the imaging study, you realize that when you do an X-ray, some of them will come with what? Cardiomegaly and signs of congestive heart failure. So with Doppler in acute rheumatic heart disease, we can use a Doppler to really help in making a diagnosis. So it is used to track the progression of valve stenosis and may help determine the time for surgical intervention. You can also use the heart characterization in chronic state. It is used to evaluate mitral and aortic valve disease. So this is cardiac MRI. It's very sensitive in detecting myocardial fibrosis. And it is superior to echo when it comes to this. So with the ECG, so we know that with the normal ECG, the PR interval should be about 3 to 5 boxes. So with these ones, usually they will have prolonged more than what I've just mentioned. And some of them will come with sinus tachycardia. Others will also come with atrial flutter, multifocal atrial tachycardia. So these are pictures that, so this is AFib, atrial flutter, multifocal atrial tachycardia. So this is sinus tachycardia. So prolonged PR interval. So histologically, pathological examination of insufficient valves may reveal varicose lesion on the line of closure. So some of them may also produce Ascough bodies. These are nodules in the heart tissue. That is characteristic of rheumatic heart disease. In the pericardium, some of them also have fibrous or serofibrous exudates that produce an appearance of bread and butter. So that this one is more of the Ascough bodies. And this is the bread and butter pericarditis. Okay, so it is important because of, as a matter of fact, rheumatic heart disease is of public health interest. And it is important for people who live in endemic areas to be screened so as to prevent the progression of the condition to a very bad state that becomes so difficult to manage. So some research shows that it is cost effective in screening rheumatic heart disease, but others also disagree. However, some recent studies show that screening could be cost effective in rheumatic heart disease, especially when it is diagnosed 2 years earlier. The use of echocardiogram is far more sensitive than, so this point basically is talking about during screening of for rheumatic heart disease with the traditional auscultation. When you are privileged or when you are likely to have echo, it's advisable to use that one because it is more sensitive in picking up valve diseases. Okay, with management. So management can be done with medically and surgically. Medical therapy in rheumatic heart disease involve attempt to prevent rheumatic fever and thus rheumatic heart disease. So both primary and secondary. So we need to prevent it primarily and secondarily. This can be achieved with oral penicillin V, 250 milligram BD, or TDS, if less than 27 kg, and 500 milligram BD, or TDS, if greater than 27 milligram. We can also use amoxicillin, 15 milligram per kg, maximum dose of 1 gram per day. We can also use a single dose of iron benzyl penicillin G, 0.6 million units, if less than 27 kg, and 1.2 million units, if greater than 27 kg. For patients with mild allergy to penicillin, obviously the patient has allergy to penicillin, you will not want to do that because of its effect. So in such cases, you need to consider the cephalosporins. However, those who also have severe allergies, you also need to consider like azithromycin and clarithromycin. Okay, with the surgical management, this may be required when heart failure persists or worsens after aggressive medical therapy. Okay, I think I've all right. So treatment of patient with rheumatic failure or rheumatic heart disease. So treatment is directed towards eliminating the group A strep, that is if it is present, and managing the heart failure. You should know that the use of NSAIDs and steroids is noted in recent times. Yes, in recent times has been seen to not improve cardiac outcomes. However, glucocorticoids like prednisolone can be used in severe carditis associated with acute rheumatic fever. So we'll consider surgical treatment when we have aggressively done medical treatment with little success. So rheumatic heart valve surgery. So for us to do, I think this one is more of the surgeons. So usually they have a specialized score they consider to see if the patient really needs surgery or not. So procedures like the commissurotomy are usually done, especially when there's um, mitral stenosis. Usually, they have to do that to open up the passage of blood to other chambers of the heart. In patients with critical stenosis, mitral valvulotomy, percutaneous balloon valvuloplasty, or mitral valve replacement may be indicated. Due to high rates of recurrent symptoms after valve repair procedures, valve replacement appears to be the preferred surgical option. It is realized that after the other surgeries, those repairs, patients still come with, the problems still persist. So it is preferred to do a valve replacement. It can also be supported. We need to consider diet management. So as much as possible, they need to be advised on nutritious diet with no restrictions except in heart failure. In heart failure, we need to consider the salt intake, water intake on that. Potassium supplementation may be necessary in patients on steroids and diuretics. So these are my references. Thank you.
All right. Thank you, Dr. Faisal, for a good job. For a good job done. We would open the floor for comments now. If you have any question, comments, kindly put up your hand, or you could even directly just unmute yourself and then you go ahead with your question. If you have any question, just unmute yourself and then you can go ahead. If as well you would want the slides of Dr. Faisal's presentation on rheumatic heart disease, kindly click on the link that I've put up in the chat box, and then you can evaluate his output as well. Put in your email address, and then we can send the slides over to you.
Good afternoon.
Good afternoon, sir.
How are you?
Very well. How about you?
I think I joined very late, but I saw doctor saying surgery for acute rheumatic heart disease. I think they just want to correct something, especially when it is acute and then you're going for surgery or there's persistent heart failure. It's usually the regurgitation or incompetence. So mentioning valvulotomy for stenosis is not one of them. It's usually regurgitation, if it is, because it's either the erosion of the valve leaflet or sometimes it's a perforation in a calf leaflet, especially if it is the aortic valve that is involved in the rheumatic heart disease. So it's a regurgitation, and usually the best options are the valve replacements. Mentioning valve stenosis and this in the acute stage is not a stenosis. It is in later phase that you get a stenosis. By then, fibrosis and this have taken place, and then healing comes up. That's just what I want to chip in. Thank you very much.
Thank you very much,
thank you, sir.
Ross. So Dr. Umar is at the National Cardiothoracic Center. It's a cardiothoracic surgeon. Obviously, we are blessed to usually have experts, of course, guide us on these presentations, and that's the beauty of these presentations. We get really top-notch people to usually make contributions, and of course, I'm sure Dr. Umar's experience with rheumatic heart disease at the National Cardiothoracic Center is definitely something worth tapping into. So we are grateful for joining us and for making that important correction and contribution. If there are any more questions, you could kindly just unmute yourself and then you go ahead with search. Dr. Pong, I see you've unmuted yourself. Please go ahead.
Yes, and good afternoon, everyone, and thank you, Dr. for this presentation. Well, I just want to talk a little about the money, and then also investigation. I did not hear anything like a true. I don't know if my network was.
Dr. Pong, I don't know if it is me, but your network seems to be breaking. Kindly reposition yourself and then go ahead.
Truth swab, then and take a swab from the throat for investigation for culture and sensitivity. And patients with actually who come with rheumatic heart disease and heart failure, you would like to put them on
Good afternoon.
Good afternoon, Dr. Ghana. I don't know if it was my network, but I seem not to have heard Dr. Opong's contribution. Since you are muted, Dr. Ghana, I don't know if you heard what you were saying.
No, I also had a lot of problems. It was breaking very frequently.
Okay. I think Dr. Opong, you have to reposition yourself, and then you could. I think it's still quite terrible. Dr. Mo, I'm going to mute you so that then you can reposition yourself and then probably make your submission again so that then we would be able to hear. Dr. Ghana, please go ahead.
Yeah, thank you very much. I thought I heard something like Ghana losing about 200 and something a year. I guess that is talking about mortality from rheumatic heart disease. What about the morbidity? What is it like in Ghana on the scale of morbidities? How does it compare? For example, we usually know nowadays, is it the NCDs that are on top, or is it malaria that is still there? What is rheumatic heart disease in terms of morbidity in Ghana?
Great. Thank you, Dr. Ghana, for that. Obviously, I'm sure if Dr. Umar is still on, the data at the National Cardiothoracic Center may be able to guide us regards what our current morbidity data in that regard is. I see we were able to get what the WHO put out as about 256 mortalities, and that Ghana ranks about 80th in the world. Dr. Umar, could you kindly help us with that regards the morbidity data?
Hello.
Hello, boss.
Yes, sir. Good afternoon once again. I'll say morbidity is sparse because we do not see the acute phases at our end. Usually it's managed at a medical block, then referred to us when patients are due for surgery. On occasion, few cases that we have to intervene and then have to go to theater, they are sparse compared to what general pertains, unless we do a whole country kind of rheumatic fever disease or rheumatic heart disease, then we can gather the data. Dr. Doku and group did something on heart failure and then causes. This did not give any meaningful listen to, and that for the rheumatic heart disease. It's just a rheumatic fever by contribution. But as to rheumatic heart disease, it's not significant. And talking about whether non-communicable diseases, where they are in terms of morbidity, it's still the infectious disease and mostly the tropical conditions like malaria, they are still leading in terms of morbidity mortalities. Cardiovascular diseases are coming up, but contribution from rheumatic heart disease is not that significant yet because we don't have a pool data. Thank you.
Thank you, boss. So I recently joined the National CBD training committee. So looking at training people on cardiovascular diseases in Ghana. Dr. Doku et al. Had some indices regards the CBDs and of course the double disease burden that we have regards the infectious diseases and of course like Dr. Omar said, the cardiovascular diseases that are now coming up. In terms of rheumatic heart disease, I think what was put at a national forum that we had in Accra last month, rheumatic heart disease came to like about number 10 among the CBDs that were put up. Obviously, the presenter did even put out that likely as we get westernized, as things are done better, as acute rheumatic fever is picked up early and prevented and the prophylaxis are adequately given, just like in the developed world where rheumatic heart disease is a rare thing that is found, we would be looking at possibly having that as going lower than even the 10th position that it was currently on. Regards the regional data, we don't seem to have any in the Upper West. I don't know where Dr. Agana is, if they have such data as well. But definitely as practice improves, as cases of acute rheumatic fever are treated promptly and adequately, definitely this rare complication of rheumatic heart disease should definitely go down the lane, just like we see in the developed world. I don't know if anyone has any more questions. Dr. Poi, if you have probably got into a good network here, you could unmute and then go ahead. I see Dr. Suleiman Eswabri, if you have any as well. Dr. Juan Agoire, both are my colleagues, specialists in Dr. Juan at the TTA, the Tamale Teaching Hospital, and a couple of other colleagues who have joined as well as Dr. Kelly Hartfield, who is the Executive Director of Ghana Medical Association, Ghana Medical Health, whose platform we are using for these meetings and for most of our meetings that we have via the Zoom. So I don't know if anyone has any comments. We still have about 5 minutes to the top of the hour. If any questions, comments, you could kindly just unmute yourself and go ahead. Okay, just to once again remind all of us that in the chat box, you realize I put in a link that you could click to provide an evaluation of what we have done. It takes just less than a minute to provide these direct responses. And at the end of that, there's an option for you to put in your email address for these slides to be sent over to you, as well as this recording. Today's presentation has been enriched by Dr. Umar and Dr. Agana. Dr. Umar is a cardiothoracic surgeon at the National Cardiothoracic Center, where usually our cases of rheumatic heart disease with the complications we end up sending to for assessment, for valvular repairs, for further management as well. And so if on those of us on the platform, if really you have any issues regards rheumatic fever, rheumatic heart disease, I'm sure it's a good platform for us to have that discussion. We have about 4 minutes. If you have any, you could go ahead. All right. So in the absence of any comments or questions, we would want to once again thank Dr. Faisal for taking us through this presentation. Want to thank all our senior colleagues as well who joined in this presentation as well. Dr. Pong, I see your hand is up. Could you kindly unmute yourself and go ahead? We couldn't hear you on the first submission. The line was terrible.
Yes, boss. Thank you very much. So I was just making an input of during the investigation. I would say I didn't hear anything like a swab. So if he did not mention a throat swab, then we can as well do a throat swab for culture and sensitivity. And then also on the management plan, there is now secondary prophylaxis for acute rheumatic fever and, for that matter, recurrent carditis, where one can be given a benzathine penicillin G. I think the adult we give 900 milligrams, and then for children you can give them 50 milligrams. So that was my input. Thank you.
Great. Thank you for that input as well. I think he captured both of them actually on his slides as he tried to demonstrate when you were making your submission, both regards the oral penicillin V and then the titers of the ASO. All right, good. Great that you brought this up as well. Okay, so thank you so much for joining us for today's presentation. We are grateful for your time and we are grateful for the contributions as well. Next week, we would look at another important topic. Kindly find it on the various platforms when it's made available. Sorry, I think next week we'll be at the Ghana Medical Association annual general meeting. So we may have to push it to the upper week. All right, thank you very much and have a great day. God bless us all. Thank you once again, Dr. Faisal. Bye-bye.